In this video, we're going to speak specifically about fluids, hypertonic, hypotonic, and isotonic. So this slide, this image right here just is a reflection of a slide I showed you earlier related to hypovolemia and hypervolemia and the different complications that arise as those volume states shift. So just a refresher, not going to go through it all right now, just to call you back as we start talking about fluids we're going to use, the environment in which you may see these things used. So fluid is moved at the capillary level. You will recall in a previous presentation and in class, we talked about how blood pressure is determined at the arterial level, and that you could make a case that sometimes even at the capillary level based on chemo and osmoreceptors and their sensing of fluid movement at the capillary level. As capillaries open, they become more permeable to fluid and they become responsive to pressures that are exerted there. So changes in plasma protein concentration, changes in the pressure of fluid moving in those places can change and alter where fluid moves across those membranes. So in this first example, when plasma moves into the interstitial fluid, that's in response to increased venous hydrostatic pressure, whether it's out in the veins of the periphery or even in the central veins, in the pulmonary vein around the heart. Changes in oncotic pressure can also cause fluid to move across these membranes. If you have a low oncotic pressure in plasma, fluid can shift out into the interstitial space. If, however, there's proteins, for example, in liver failure in the interstitial space that can draw fluids into the interstitial space. That shift of plasma from the vascular space into the interstitial fluid. And conversely, it can move the other way. So if you have a high concentration of protein in the bloodstream, that can cause fluid to move from the interstitial space back to the plasma. And if you have an elevation of hydrostatic pressure in those spaces, that can also create a movement back into the vascular space. The primary mover and driver is going to be osmolarity. This is the normal range of plasma osmolarity in the human being. And solutions will vary a bit around these numbers, and we refer to them based on, again, the intracellular environment, whether it's hypertonic or hypotonic. Now, I don't want you to get real particular and be thinking that just because a solution is 284 or 83 milliosmoles, that we call that hypotonic. We're not that rigid with this this range. What I want you to be referencing in your mind is 300. An isotonic solution, as I've already mentioned, is a normal saline. 9% sodium chloride is an example of such. And it's basically a vascular fluid replacement. It's going to go into the vascular space, stay in the vascular space as long as the patient is not dehydrated or in fluid overload. It's a common diluent for most medications. And noteworthy here, it's the only fluid that can be given with blood products. It's the only one that can go in the tubing to prime the blood tubing, and it's the only one, if fluid needed to be given along with sodium chloride, along with blood, and we didn't have another choice, we could give a bolus of fluid with a bolus of saline with blood, but that commonly is very uncommon and is only used sometimes if you need to dilute the blood to get it to flow a little better and get it in on time. Again, normal saline is the only fluid that can be used with blood products or prime blood tubing. Lactida Ringer's is an example of another isotonic solution. So it also can replace intravascular volume. However, it contains sodium, potassium chloride, calcium, and lactate, which means it doesn't just have sodium and chloride in it. It has other elements and other compounds to create a similar osmolarity as that of the blood. So we still refer to it as an isotonic solution. It's used in a different context. We talked about some of these in class. And a good example of where you will see this is you will see this ordered on patients before they go to surgery because they have been NPO, and the doctors would like for them to have some critical electrolytes, sodium, potassium, calcium, and chloride, and lactate, going into surgery to help prevent and circumvent any complications that could arise from the fact that they've been NPO for 12 to 24 hours. So this is commonly used in the perioperative area, both before, in recovery, and sometimes for a bag of fluid after surgery is the common place for lactated ringers. Dextrose, D5W, 5% dextrose, is considered a hypotonic solution, not just because the number's 252. That's pretty close. However, what makes this a hypotonic solution is this point right down here. Dextrose is quickly metabolized. When dextrose is metabolized, then water easily moves from vessels into cells because it is a hypotonic. It's just water. So that is definitely a hypotonic solution. We use it often to treat dehydration and hypernatremia when sodium is high. So we will use that to address water losses when patients are dehydrated. Again, water losses, not blood losses. Hypertonic solutions, I've already given you one example, and that's the 3% sodium chloride solution. 5% also is hypertonic. But here you have also dextrose 5% in lactated ringers and dextrose in normal saline. Remember, both saline and lactated ringers are isotonic solutions. So if you add dextrose, you're adding a solvent, which is going to make that a hypertonic solution. Bear in mind, though, it's also going to metabolize quickly, just like the dextrose in water. They refer to these fluids as volume expanders. When you put them in the vascular space, they draw fluid to them from the interstitial or the intracellular space. So we could use those to treat hyponatremia if we needed to. Rarely you're going to see that to manage hyponatremia, but they help bring fluid into the vascular space and possibly help expand it. This slide is meant to illustrate to you how the different solutions are composed and what osmolarity that creates. So here's two dextrose solutions, D5W and D10W. And you see in this graph that D5 has 50 grams of glucose in it, which creates an osmolarity of 252. When you double that to D10, you have 100 grams, which raises the osmolarity in that solution to 555. Again, those are going to be metabolized fairly quickly, but you can see that their osmolarity is changed by the single compound that is diluted in that solution. Now, the best illustration of iso, hypo, and hypertonic are the salines, as I've mentioned before. So if you look at this middle one, 0.9% sodium chloride, there's 154 milliequivalents of sodium, 154 milliequivalents of chloride, which creates an osmolarity of 308, which is isotonic. It's the same as what's in the body. If we half that concentration, so half normal saline, as you see here, has 77 milliequivalents of sodium and 77 of chloride, that creates half that solution. And then if we triple it, you see that it can be 3 times that value. So saline, normal saline, sodium chloride, 0.9% is isotonic. Half normal is hypotonic, and 3% saline is hypertonic. This slide is not for you to memorize, and please don't memorize these numbers. What I want you to see is what is creating the osmolarity of these solutions and what's clearly making them hypo, hyper, or isotonic. Crystalloids, I like to jokingly say, are referred to as IV fluids. Basically, It's any salt or electrolyte solution that when you take the fluid out, the solute becomes a crystal. So that basically encompasses almost all of our IV solutions. These fluids are capable of passing through semipermeable membranes. Another term you're going to hear is colloids, and there's really one thing to remember here. Colloids are basically albumin. They are solutions that use a molecule to create or to serve as the solute. So a molecule, like protein, is the solutes, and it is a hypertonic solution that will draw fluid into the vascular space, and it therefore is also referred to as a plasma expander or volume expander. The force that is generated when we administer albumin is oncotic pressure. So I just want to remind you of that. So when you think of colloids, you think of albumin, and when you think of albumin, you think of oncotic pressure. The next slide is going to pick up with regulation, and we will elaborate on the different components that regulate fluid movement and blood pressure.